Bismillah ar-Rahman ar-Rahim. Thank you very much for the kind invitation, Professor Khalid, and thank you very much for a great program. Let me speak to you about Safari technique, which have affected my practice over the last few years. Well, what is Safari? It means subintimal arterial flossing with antegrade retrograde intervention. This is the abbreviation of Safari. It was first described by David Spinoza, and this is the paper that has been published with his work in 1990, so it's quite a long procedure. Well, there are, if you're doing peripheral intervention, there are things that need to be defined, like Safari, cart, and reverse cart technique. Well, Safari technique, basically you go with the wire between antegrade and retrograde, and you try to have a rendezvous over these two lumen. Cart technique is a technique used by cardiology for retrograde inflation of a balloon to open a track, and then you go antegrade. Reverse cart is quite the reverse. You do the balloon from above, and then you do retrograde. Well, this is the how you have a, if you have a CTO, first you try to pass the wire, and you can use micro channel if you have a tip of 0.008 just to hit the total occlusion. And this is the antegrade approach. The parallel wire approach was an appealing idea. If your wire go to subintimal, leave it and take another wire. You can even have a third wire to block two subintimal techniques. Now, the star technique, you can use a balloon to open or crack the occlusion, and then you pass your wire. And this is subintimal crackling. The cart technique, as I described, you go with the balloon from retrograde to open the channel, and this is the cart technique which we have adopted from the cardiologist. Reverse cart technique, just the balloon goes from above and you go from retrograde approach. This is a knuckle wire approach, which is a nice idea. You make a knuckle into your wire, and then you try to hit this knuckle with two views of your peripheral intervention. This is the technique of the Safari technique. If you can play in this video. This is a video to explain the Safari principle. Probably it wouldn't work. I will write. So this slide actually took me 6 months to do. This is there are 3 videos that will play simultaneously. This is how I do retrograde recanalization through the 3 tibial artery, the AT zone 3, the PT zone 3, and the peroneal zone 3. Each one have its special technique, and you can use both radiological imaging or duplex guided techniques. And it's become now quite a standard technique to do the retrograde approach, because this is an essential part of doing Safari. So these are the 3 techniques. I prefer the ultrasound guided, where you can do it by duplex scan. You can see the 2 vena comitant, and you go straight away. And ultrasound technique actually will develop. It will have a GBS guiding needle, which can actually guide you through the needle, which make things are very simple. So the one on the right side, you can see what is called the needle tracking software, which is now found in Philips and multiple software, which make really puncture to be quite an easy maneuver to do. But you can still use imaging if you don't have duplex in your angio suite. This is a case of Safari technique, which there was, I went to antegrade. This is diabetic patient, hypertensive, with total SFA occlusion, that you can see the upper part of it. Can the video play? Don't want to press anything. So with this video, I went into antegrade. The wire didn't go, and then I went retrograde, posterior tibial. I went up. I hope it works, this video. We did it, check it twice. It's playing, okay. So I went with the wire antegrade, didn't go, which is not uncommon, it's 40%. I've tried to summarize the whole intervention into just one video, which is the one on the right side. This is, you can see the runoff. You injected the IC. Where is the runoff? Which is the lower third zone 3, SFA. You can puncture zone 3 SFA. I did give a little bit of local anesthesia. And then after that, I went with retrograde to the SFA. And you can see this is a distal runoff to make sure, because at the end of the procedure, you want to know that you haven't embolized. This is, I'm injecting xylocaine around the SFA to ease up the pain with just a Seldinger needle around the SFA. And you can see the calcification in the SFA. And after that, I went with the needle, retrograde, and the wire, and you can see the needle went through the arteries by the calcification, and then you pass the wire retrograde, and you try to make rendezvous. Usually you go with a catheter, 5 or 6 French catheter, best to have a curved catheter, and you try to direct the curved catheter towards the wall. This was a perforation that happened when I went antegrade. So perforation is not a contraindication to complete the procedure. You can see this is a retrograde wire going from the anterior tibial artery, going upwards. And here is the wire. You try to navigate your wire. And you must have double imaging. You must have an AP and lateral view. And you do multiple balloon dilatation, although you haven't done the rendezvous yet, but you do multiple balloon dilatation because you are in the retrograde approach. You are not widening the dissection. And after that, you hit this is antegrade, retrograde flossing. And then you do the rendezvous. You can see the trick about the rendezvous is that you make the angled catheter look at the wall. And then you make the wire to hit the wall. And then it will redirect again into the catheter. And this is what happened. And then after that, straightforward balloon dilatation. And the perforation has stopped. And I use, I think in this case, one of the superior stent. And this is the imaging after finishing the procedure. So this is basically a collection of the Safari techniques that I have used. Now there is the Copidon strike technique, which is extremely appealing technique. And this is a technique which has converted the arteriovenous fistula to be done endovascular with on-shelf tools. So what is basically is you go with a wire and with a wire from down below, which have a hook and the loop, and you go from above, and you try to pass the Seldinger needle into these two wires. So this is the Copidon technique, and you put a snare down, a snare up, so you have 2 rings, one in the vein, one in the artery. So what is left is you pass a Seldinger needle hitting 2 rings, and then you push the one below, so this is the wire in the vein, and one above, wire in the artery. And here you have your technique. So this is very appealing. No one knows which one has started for the arteriovenous fistula. I'm putting next, yeah. So this is the Copidon technique. It's not my video. This is a video from the Interventional Society of Radiology. And it will work, yes. You can see one snare, pull the wire above, and one snare, pull it below, and this is how it's being done. So this is the summary of the Safari technique, which I have used quite a lot, which has actually dropped my failure in SFA intervention really quite around 20% after using Safari technique. Thank you very much.